in the chest wall versus pleura. I told you if I see a single rib destruction suggestive of a mass, osteomyelitis, then there is no part of this mass which is bulging in the lateral chest wall. Yeah, the muscles of the lateral chest wall are looking absolutely neat and clean. So I am most likely dealing with a pleural effusion or a pleural mass. And what should I do next? I should do an ultrasound next. So that is how it helps, because it helps you to suggest the next modality. The next modality can be an ultrasound, it can be a lateral radiograph, it can be a CT. It's not the same for everybody. That's why I have to make up my mind on a chest radiograph, and I can't say that it doesn't matter. I have to do a CT in any case. The next radiograph shows you loculated fluid in the minor fissure. We will see more examples of these. So as I said, on the medial side, the angle sign still shows you acute angles. But can you see all the borders? So in the parenchymal lesion, we said all borders should be visible, but I cannot see the lateral border. Can I differentiate it confidently from a peripherally placed parenchymal mass? No, I cannot. So you cannot always tell, but following the fact that one border is lost and the margins are very sharp, I tend to think that it is likely to be an extraparenchymal lesion. Similarly, an example of the incomplete border sign. Whenever a lesion is in the chest wall, however well defined some of the borders will look, there will be a border which will completely blur out. Unlike the lung lesion, when one border completely phases out or zones out, you know that you may be dealing with an opacity outside the lung, because a lot of people can mistake this chest radiograph lesion for a parenchymal lesion, while actually it's a chest wall, because I can't see the inferior border. Laterally it's touching the chest wall and I cannot see the inferior border also. This is called the incomplete border or cutaneous silhouette sign. Various other signs described for, so this we discussed epicenter of the lesion, and we discussed the angle sign, and we discussed what happens when you do a lateral radiograph. Now there are several named signs, as you are aware, for localization within the mediastinum and the lobes, and we will first discuss each of them one by one. Silhouette sign. Silhouette sign actually is loss of silhouette, loss of a border. So you see the heart contains blood, yeah, the vessels which are going out of it also contains blood. From the X-rays point of view, blood is water. So water is appearing white to you, lung appears black. Between the two there is a sharp interface, because there is water on one side and there is air on one side, so you get a border. But what happens if these air-filled alveoli get filled with fluid? If there is pneumonia, there is hemorrhage, and the alveoli get filled with fluid, then both sides there is fluid. If both sides there is fluid, there is no border. But for this border to go, these two structures should be lying next to each other. So these are the two criteria. They should lie next to each other, and if they are of equivalent density, there will be no border. This sign allows you to say whether the lesion is anterior or posterior, and applies both to pulmonary and mediastinal lesions. So what are the anteriorly placed structures in the lung and the mediastinum? So if there is obliteration of your right heart border, left heart border, or ascending aorta, it's an anteriorly located lesion, which is anterior segment of right upper lobe, the right middle lobe, anterior mediastinum, or on the left side corresponding anterior segment of left upper lobe, lingula, anterior mediastinum, and even loculated pleural effusions. So for instance, this is a parenchymal lesion in the right upper and mid zones. Hilum is also enlarged. You can't see where the border of the ascending aorta should have been. It is again zoned out. You only see a continuous density. So this is the loss of the silhouette. Applying the silhouette sign, we know that this lesion has to be anteriorly located. So the anterior segment of the right upper lobe has to be involved, as is shown in the CT, that the entire right upper lobe was involved, and the sharp lower border that you see is the pulled up fissure. Here is another lesion which is lying along the left heart border next to it, but see how clearly you are seeing the left heart border. So it's lying next to it apparently on the frontal radiograph, but the border is very clearly seen. What does this mean? That the lesion is not anteriorly located. So it is not in the lingular, not in the upper lobe, so it's more likely to be in the left lower lobe. Yeah. That's the CT scan confirming its location in the left lower lobe. Similarly, the same anti-mediastinal lesion we saw earlier, we know that it has obliterated the right heart border, so anteriorly located the lesion, in most probably a thymic lesion. If patient has myasthenia gravis, you have made the diagnosis on chest radiograph itself. Then what happens in this mediastinal widening? Both sides the silhouette is gone. You can't, right heart border can't be made out, left heart border can't be made out, the aortic knuckle can't be made out. So how do we say it's anterior or posterior? Because it's a multi-compartmental mass which may be silhouetting multiple structures. But herein, if we go for the lateral radiograph, you can see, what did we see in the lateral radiograph? Black area behind the sternum, which we labeled as a retrosternal lucency. Now this retrosternal lucency is obliterated, gone, if the lesion is located in anterior mediastinum. We are done with the anterior lesions. Now the posterior lesions. What in the heart border is posterior? Basically the aortic knob, the knuckle as well as the descending aorta, it continues into, are posteriorly located. So if the lesion is located in apico-posterior segment of left upper lobe, posterior segment of right upper lobe, or in either of the lower lobes, it will obliterate posteriorly located structures. Nothing in the right heart border is posteriorly located, as you can see. So it's basically the left heart border which gets obliterated by these posteriorly lying structures. So similarly, we see a mass in the upper and mid zones, left heart border, knuckle completely obliterated. CT confirms location is primarily posterior. Another posterior mediastinal lesion, we have performed a lateral radiograph. So what happened in the lateral radiograph? In the anteriorly placed lesions, the retrosternal lucency went away. But in this case, the retrosternal lucency is gloriously seen, it's dark, and the lesion is confirmed as being posteriorly located. Was the silhouette sign correct if we used on the frontal radiograph? Yes, it was, because you can see the left heart border very clearly. Is it a good radiograph, frontal, to comment on the silhouette sign? In this particular case, no, because it's really an over penetrated, this was a penetrated view. That's the other caveat to remember, that the penetration of the radiograph should be just correct, otherwise the silhouette sign loses its significance. Now the heart border is not the only structure which can get silhouetted, the diaphragm can also get silhouetted. Whatever silhouettes the diaphragm is located in the lower lobes or in the posterior part of the pleura. So let's see examples of these. Now we have a lesion which looks like a consolidation, shows air bronchogram, obliterates part of the diaphragm, most of the diaphragm in fact, so we know that it's located in the lower lobe. But you may argue it also obliterates the right heart border. What does that mean? For right heart border, we said middle lobe. So this is a combined consolidation, so you can differentiate also that whether it's isolated middle lobe consolidation, isolated lower lobe consolidation, or a combined consolidation on basis of the silhouette sign. As I already mentioned, the caveats are the quality of the film. It should be an adequately penetrated film. The two lesions should be of equivalent density, roughly of water density, and lesions which are not in anatomic continuity, means it may be anterior, but it's a sternal lesion. So, lesions which are far anterior or far posterior also do not silhouette the heart border. Next sign used for location is cervicothoracic sign. Essentially, the cervicothoracic and thoraco-abdominal signs are when you see lesions which are in the upper part of the mediastinum, you want to know, did the thyroid come down or is it primarily a thoracic lesion. Similarly, when you see one lower down, you want to know, is it just a hiatus hernia or even an aortic aneurysm, a thoraco-abdominal lesion or a completely thoracic lesion which is just projecting in the frontal radiograph. So, let us just see the difference. The arrow points to a very well defined border of the mass which is seen above the level of the clavicle. So, if you see a very well defined border like this above the clavicle, it means posterior location, it means posteriorly located lesion. While on the left side, when you see there's soft tissue in the neck also, it's causing a tracheal deviation. Then the border after the clavicle, when you're following it, the border of the mediastinal and the cervical lesion are not in continuity. You don't get a very good border. So, in fact, when you don't get a good border, it means that part of this lesion is in the neck. Part of this. So, if you lose the border above the clavicle, it means anteriorly located lesion, part of which could be in the neck. When you get a very well defined border, it means that the lesion is located in the posterior mediastinum, and most commonly in this location would be a neurogenic tumor. So, a neurogenic tumor can be diagnosed on the basis of a radiograph alone, especially if you see it shows you some ancillary signs like thinning of the posterior end of the vertebrae, as seen here also. The posterior ends of the second and third vertebrae are a little thin because these are benign lesions which cause thinning of the ribs over a period of time. So, the MR confirms the posterior mediastinal location. The thoraco-abdominal sign says if you can see the margins very well, the margins are very well and they come towards the spine, that means the lesion is completely intrathoracic. So, let us see an example. The arrow shows you there is a lesion which looks partly in the abdomen and partly in the thorax, but if you see the lower end of the lesion, it converges towards the spine. You can see the borders very well. This is the converging, and if you see the MR, it's thoracic neuroblastoma, completely intrathoracic lesion. So, this is the thoraco-abdominal sign. On the other hand, if this margin went out, it diverged, which means that part of the lesion is truly thoraco-abdominal, means part of it is in the thorax and part is in the abdomen. Last sign for localization is what is referred to as hilum convergence and hilum overlay. Basically, hilum is a vascular structure from which all the vessels take off. So, if you have a vascular lesion, means just enlargement of the pulmonary artery, all the branches are going to converge towards that lesion, which is known as the convergence sign, that all the branches lead up to that mass lesion, that is a convergence sign. On the other hand, if you can see that entire division through the mass, which means that it is not a vascular lesion, it is located anterior or posterior to the hilum, which is called the hilum overlay sign. So, let us see an example. Herein we have a mediastinal mass which is not silhouetting the heart border, so likely posteriorly located. The arrow shows you the entire Y-shaped structure of the hilum, which can be seen through the mass. This is the hilum overlay sign, which means it is not a vascular mass, but it is a truly mediastinal mass. We see 2-3 examples to see that are there any specific pointers like we saw in neurogenic tumor that you can make a diagnosis on the radiograph itself. So, right paratracheal stripe widened, right hilum enlarged, convex outside, increased density along the descending pulmonary artery, again lobulated, which means bronchopulmonary node also involved. So, lobulated margins, which means that you are dealing with nodes. you don't need to go in and do a chest CT to confirm these unless you want to do it for a differential diagnosis. So these ancillary signs can help you. On the other hand, this is a patient which came to us last week in casualty with sudden onset abdominal pain. Yeah? So let me give you a more penetrated view. There is a lesion which is running along the spine, which is going thoraco-abdominal. Now I try to apply the thoraco-abdominal sign and see, is it a thoracic posterior mediastinal mass or is it a true thoraco-abdominal lesion? So in the abdomen, no converging borders. The borders continue the way they are in the mediastinum. They just continue down parallel. They do not come towards the spine, which means there is a lesion which involves the thorax and the abdomen. In that case, firstly you think of esophagus, you think of aorta, and we went on to do an ultrasound. So as I said, everything is not CT, so this is a thoraco-abdominal lesion. Patient has come to casualty, we do an ultrasound which showed us a through and through dissection, and a subsequent CTA showed combination of type A, type B, and we lost the patient within an hour. So that is why important to take decision on the chest radiograph using all these signs, that what do you want to do next. Typical signs also described for thymus: the wavy contour, impression of the anterior ends of the ribs giving it the wave sign, and the shape referred to as sail sign. Why does this happen? Why does the thymus give you these signs? Why doesn't any anterior mediastinal mass do it? Because a normal thymus is a very soft and compliant structure. So it allows indentation of the anterior ends of the rib on its border, which take on this kind of wavy contour, and that's why if you see the wave sign, you are sure in an appropriate age group that it's only the thymus and you don't have to unnecessarily investigate further. A very good ancillary is just to do an ultrasound and confirm it. So again, no CT scan. As I told you, we will go on to the abnormalities in part 2, and you need to read cardiac basics of cardiac congenital and acquired disorders separately, which we are not covering here. Thank you.